I'm going to get everyone started. Just a show of hands in the audience who works pretty regularly with OCD. Okay, so we have about half of you. Okay, wonderful. Our learning objectives today were to introduce you a little bit to differential diagnosis, right? There are a bunch of disorders that can kind of mimic OCD, and sometimes they're difficult to differentiate. So I'm going to talk a little bit about that section. There you go. And then Megan's going to talk to you about the common themes and subtypes of OCD, you know, the more common ones that you're familiar with, and then the ones that are a little bit trickier sometimes to identify as OCD. And then lastly, Megan's going to talk about first-line evidence-based treatments for OCD. Okay, so for those of you who don't know, just a reminder, there's characteristics of obsessions. This becomes important because sometimes some of the other disorders can look similar because repetitive ruminating thoughts are very common across many psychiatric conditions, right? There's a mental component to it. OCD is a little bit different in that the obsessions are very repetitive and they're unwanted and intrusive. So this is not the same as a fantasy or an interest in say ASD, where people with autism, you know, have a particular interest in something like planes and flight paths of birds and stuff. They enjoy it. There's a sense of pleasure when you think about that. Whereas in OCD, it's unwanted, it's intrusive. So that's an important distinguishing characteristics. They're also not reasonable. So they can start off sounding kind of reasonable, and then if you talk to the patient enough, you'll see that it becomes more and more unlikely, improbable, and sometimes difficult to follow. So that's another distinguishing characteristic. They're excessive. You know, they occur many hours a day. The Y box is one measure you can look at for severity, but a lot of people will describe 3 to 8 hours or more of these intrusive, pop-in thoughts. Obviously, they produce distress. And just to note, they're not always thoughts. Some people just see images, especially when you question people about the more like violent obsessions. They can look very much like images in their head, which you can imagine is pretty disturbing. Okay, so characteristics of compulsions. Just to distinguish, there's two kinds. The ones that are more overt and observable to most of us, we're pretty familiar with that, right? Ordering, arranging, repeating, checking, washing. Those are the ones people are familiar with. The covert mental ones are where it can get very difficult to identify, and I think personally are much more difficult for the patient to try to work on and control. And as far as strategies that we struggle with to work on these, I would say pure O is a myth, right? You would agree after all these years of treating OCD. A lot of times you'll see this pop-in thought. The mental compulsions, there is a voluntary aspect to that. So I've never seen a patient that just had obsessions. In fact, when they're ruminating and reviewing and thinking about it and problem solving, that's more of a mental compulsion rather than an obsession. An obsession is sort of that quick pop-in thought. So one thing I think that can really mask the severity of OCD is the avoidance factor. So there's direct avoidance, right? I won't touch certain things. I won't go out on certain days of the month because it's an unlucky number. So those are obvious and they're distressing. And obviously people can't go to work or school because of it. But the more passive avoidance is where especially children or adults too, can get family members to perform activities for them. So a patient will say, I didn't wash today. And we'll say, what did you do today? And they said, oh, nothing. My mom made dinner for me and lunch, and she turned on the faucet and did everything for me, so I didn't have to wash. So that can look like it was a good day, but if you question it further, it's because they weren't really engaging in activities that would bring on those obsessions and compulsions. Okay, so kind of the OCD cycle. Sometimes there's an internal trigger, sometimes there's an external trigger, sometimes the thoughts just pop in, right? This intrusive fear pops in, this what if thought. A lot of times it's a what if thought. The person with OCD experiences a whole host of negative emotions. It's not always anxiety. Sometimes it's described as disgust, shame, guilt, just a general discomfort. And as a result of that, the person with OCD will engage in these compulsions or safety-seeking behaviors, and that becomes negatively reinforcing because when you do these compulsions, at least for the minute or two that the person engages in them, there's this immediate sense of like relief. Unfortunately, the relief is not long-lasting. Within a minute or two, the anxiety might, come up again, and then you're kind of stuck in this OCD cycle. And our treatment really is aimed at breaking this cycle. Okay, so I'm not going to get through all of these in 10 minutes. There's probably more, but differential diagnosis between, I was trying to go over some of the top ones. GAD is one that trips a lot of people up. Illness, anxiety, specific phobias, threats, ASD, psychosis, ADHD, and then distinguishing it from the other OCD-related conditions. People with depression and PTSD also have repetitive ruminating and sometimes intrusive thoughts, so that can mask itself as well. Okay, so OCD and GAD. So most of you are familiar with kind of the diagnostic of GAD, right? It's a very common disorder. I would just say that sometimes you can have both. So if you're confused, if there is the possibility that it's comorbid. Somebody can have OCD and GAD, right? So in both cases, there's repetitive thoughts. Sometimes they're thought is unwanted, even in GAD. There's the what ifs, the catastrophizing. You might see some what looks like compulsions in the way of seeking reassurance, talking about it a lot, right? Like, what if I lose my job? What will happen? I won't be able to pay my bills. So there can be this kind of ruminating and repetitive conversation that happens as a result of GAD. What you will find, though, in OCD, that the thoughts and sort of compulsions are much more persistent, intrusive. They're not always triggered necessarily by a real life situation. So the person may not be working that day and worrying about their job because they just heard about 50% layoffs in the company, right? They might be catastrophizing. Somebody with OCD, the thoughts may start off sounding like, hey, what if I lose my job? Or what if my family isn't safe? Or what if something happens to my child and they get sick? It kind of starts like GAD, but what you will then see is, what do you do in response to those thoughts? And somebody with GAD was like, I just talk about it, I worry about it, I think about it, my stomach hurts, I have all these physical symptoms. Whereas somebody with OCD might say, well, then I start to count in sets of 3. Then, I ask for reassurance a lot. I started praying. And you'll say, how did you pray? So, well, I have to do it in a certain way. Well, what if you mess up the prayer? Then I have to start over again. So there is this kind of repetitive, ritualistic, and in a way, disconnected response to it. And that's one way to distinguish OCD from GAD. So they had to throw us off in the DSM-5. Hypochondriasis, we always thought was an OCD-related condition, but they took it out of the OCD-related conditions. I guess there wasn't enough research. And then they added the somatic symptom disorder in it. There's a lot of overlap. I think if you click again, I did a animation. Oh, okay. Worked. So the commonality is a worry about health, disease, right? It's repetitive, it's intrusive. There's a lot of catastrophizing. Again, you might see something that looks like you might see things that look like compulsions, right? There's a lot, but what you will see in somatic disorder and illness phobia is that it tends to be like body checking, researching online, WebMD, a lot of doctor visits. Although some people with illness phobia are like care avoidant, so they won't go to doctors because they don't want to hear the worst news ever, whereas other people will repeatedly go to doctors. Again, the difference in like somatic OCD versus the other two. Cool, right?
Makes your life easier.
Yes. What you will see again in OCD is that it tends to be more like what will have like the contamination, right? So then I have to wash repeatedly. I have to wash for 5 minutes. I have to wash in sets of 3. I can't use this sink because that one will get me dirty. They actually have better insight than the other two disorders, but the rituals are much more excessive, unrealistic. Somebody with somatic symptom or illness phobia might ask people, will I get sick, or do you think this symptom is a sign of something terrible? Somebody with OCD will kind of do it more repetitively, kind of insistently in the same way, whereas the other two kind of like, they'll do it once or twice and then they'll walk away from it. And they might check again, but there's this sameness and routine that goes along with the somatic OCD. Are you going to talk about the sensory OCD piece too? Okay, so I'll leave that for Megan. Okay.
I just have a question.
Sure.
Going back to better insight, what do you Can you explain that a little bit more?
Sure. I mean, as unreasonable as the thoughts are in OCD, for the most part, if you question people enough, they do doubt. They recognize that their thoughts are intrusive and unwanted. It is on a continuum in OCD from good insight to like delusional poor insight as well. But usually you can question somebody. Or someone with illness phobia and somatic symptoms, like, maybe it could be an illness, right? Because I'm having stomach aches, or people in my family have had a history of cancer. So it's harder for them to recognize the rationality of it. Not always, there's always an exception. So quickly in phobias, it's a very specific object, animal, situation, right? They tend to function well. Their predominant coping mechanism is not rituals, it's more mainly avoidance. They might engage in like checking and scanning the environment. Like, so if you have a fear of spiders or something, when you're in the basement, you're either going to avoid your basement, or when you go down there, you're going to be looking repeatedly for spiders everywhere. Whereas someone with OCD is not just afraid of spiders, they're afraid of getting dirty, they're afraid of then getting bit by a spider and then something bad happening to their family, or, they're not just afraid of a dog, they're afraid of a dog because the dog might bite them and then they'll get contaminated with rabies and then they're going to bring it home to their family and everybody's going to get sick. So it becomes much more pervasive than you would see in a phobia. Emetophobia versus OCD, that could be a whole other talk, but just to point that out, sometimes emetophobia is just a simple phobia, and sometimes you'll see it more as like a presentation in OCD. Again, when there's a magical aspect to it, not just avoidance of certain foods and worrying about body symptoms, but it becomes more kind of larger and harder to follow clinically. OCD and tics. The simple tics, I think, are easier. Sometimes there's complex tics that involve multiple body actions that can look pretty voluntary. It can look like a compulsion. I would just say to ask for the function of the behavior, right? And in tics, it feels like this internal urge, like an itch, an urge to sneeze. I always describe it as like that feeling right before a sneeze or an itch. You just, have this internal sensation, this premonitory urge. Whereas in OCD, they'll say, yeah, I know I'm doing the behavior. I'm aware it's because X, Y, and Z will not happen if I don't do it in this particular order. So that's one way to distinguish. I would say then there's this Tourette OCD that people write about, where it sounds pretty much like a combination of both, where sometimes they'll do the tic for the right feeling, or they'll do it on one part of their body. They have to even it out on the other. It just doesn't feel right? Or they'll do it. I had a patient who had both OCD and Tourette's, and it started with like a neck twitch, and then he would do it voluntarily in sets of 3 because it just didn't feel right the first time. Sometimes the treatment is really just to say you're still working on exposure, you're working on triggers and response prevention. ASD, again, could be a whole other talk. I would say if there is just ASD alone, it's much clearer to diagnose. Sometimes you have comorbidity. Some of the diagnostic clues is to look for the presence of other ASD symptoms. And I think most importantly is to look at the function of the behavior, right? So in ASD, there's a need to emotionally regulate, right? There's a need for sameness, or it's a stimulation behavior. And it brings a sense of calm and regulation, right? Whereas in OCD, it's something the person is an action they don't really want to be doing. It's meant to reduce anxiety, it's to prevent a feared outcome, and it's more driven by intrusive thoughts than maybe an internal regulation. OCD versus psychosis?
I have a question.
Oh, sorry. Sure.
I have a question for the OCD versus ASD.
Sure.
How do you tell the difference between like a fixation for ASD and an obsession for OCD?
That's very good. So are you talking like fixation if there's like interest in something? So that tends to be more voluntary and it brings pleasure. Like the person enjoys it, they want to talk about it a lot. Where someone with OCD does not want those thoughts. They're like scary, or something bad will happen, or I'll get sick, or my family will die. So they don't really want to be engaged with the thoughts. Or someone with ASD is like, can we talk about my interest repeatedly? And it might be annoying to other people, but to them, they're enjoying that. So, yeah. Okay. So OCD and psychosis, some of the thoughts, again, because they can sound odd to us, Again, the patient recognizes them. Otherwise, they're intact. They're related. They don't have other odd, belief systems. They don't have other hallucinations. So it's just that OCD belief. And if you question it enough, they will recognize that it's not, it doesn't make sense. Sometimes you'll see people with sensory experiences at OCD, like they can feel the germs land on them, which is not possible. It can sound like a hallucination, right? Or like a tactile experience, or I can hear glass breaking in the other room. I had a patient who could swear she felt something from the neighbor's TV landing on her. And on the surface level, it sounded like psychosis, but she recognized it just didn't make sense. And it was the only place that she had that kind of thought disorder. So she's not thought disorders, which is OCD. Okay. So just questions to think about. Presence of the ritualistic behaviors. Many disorders don't have rituals in the same way that OCD does. What is the function of the behavior? What is the content of the thoughts? And sometimes you just have to look at the clinical history. Is there an OCD, other symptoms that occurred earlier in the person's life? Often OCD can show in childhood and early adolescence. So even at the moment that you're doing the evaluation, are there other obsessions and compulsions? And what is the avoidance? And you can always consider comorbidity. I think you're going to go over this, right? These are just for your benefit if you need some other measures to assess the severity of the presence of OCD. There's the OCI, there's the FOCI, and then the Y box. There's a checklist, and then just a quick 11-question measure that assesses the severity very well. That's it. Thank you, everyone.